All right, let's jump right in. The ECG, I know for a lot of people, it just looks like a bunch of squiggly lines on a page. It can feel like you're trying to crack some kind of complex, intimidating code. But what if I told you that by the end of this, you won't see a code at all? You'll see a story. And really, that's it. That is the core idea we're going to unpack today. Forget about deciphering a secret language. We are simply learning to read the narrative of every single heartbeat. And trust me, it's a powerful story, and you're about to become fluent. So before you can read any story, you've got to understand the language it's written in. What is that pen, that little stylus, actually drawing? What are we measuring here? And here is the absolute key point. An ECG is all about electricity. It's measuring depolarization. That's the wave of positive charge from sodium ions flooding into the heart cells. Think of it as the electrical command for the muscle to contract. It also measures repolarization, which is just the electrical reset. Now, the squeeze, the mechanical pump, that's the result. But the ECG, it only shows us the command itself. Okay, so every story is built from letters and words, right? Well, for the ECG, those letters are the individual electrical events that create the distinct shapes, the waveforms, we see on the paper. So let's trace that alphabet right from the very beginning. It all kicks off in the SA node, which is the heart's natural pacemaker. From there, the signal spreads out across the atria, causing them to fire. Then, and this is critical, there's a little pause at the AV node. After that pause, the signal absolutely zips down the His-Purkinje system. You can think of this as an electrical superhighway to light up the ventricles. This exact sequence is what draws the ECG trace you see. And that brings us to our very first letter, the P wave. When you see this small initial bump on the ECG, what you're really looking at is the story of the atria depolarizing. You're watching the electrical signal from the SA node spread across them. Now, the shape of that P wave tells its own little story. A normal P wave is small and kind of rounded, but if it gets really tall and peaked, it suggests the right atrium is enlarged. We call that P pulmonale. If it gets broad, maybe with a little notch in it, that points towards the left atrium, P mitrale. So the shape of the wave itself can give you clues about the heart's anatomy. Pretty cool, right? All right, next up is the main event, the QRS complex. This big, sharp, spiky thing is the sound and the fury of the ventricles depolarizing. And I want you to pay a close attention to that timing. It's gotta be fast. We're talking less than 120 milliseconds. So why? Why so fast? It's because a narrow QRS tells you that the electrical signal took the correct path. It went down that superhighway we were talking about. A wide QRS, that's a huge red flag. It means the electricity took some slow, abnormal detour through the muscle itself. So remember, narrow is good. It means the system is working just like it should. After that big, dramatic QRS, things calm down a bit with the T wave. This is all about ventricular repolarization. It's the cells resetting their electrical charge, mostly by pushing potassium ions out. Think of it as the ventricles recharging their batteries, getting ready for the very next beat. It's kind of like the story's quiet falling action. But hey, don't underestimate the T wave. Its shape gives us some incredibly important clues. If you see T waves that are unusually tall and pointy, almost like a tent, that can be one of the very first signs of high potassium in the blood, or hyperkalemia. And if they're flipped upside down, inverted, that can signal ischemia, which means the heart muscle isn't getting enough oxygen. You know, it's not just the waves that matter. The spaces between them tell a huge part of the story too. The PR interval, that measures the delay in the AV node. If it's too long, you're looking at a heart block. Then there's the QT interval. It covers the entire ventricular story, from the moment they fire to the moment they reset. A long QT interval is really dangerous because it puts the patient at risk for life-threatening arrhythmias like torsades de pointes. Okay, we've learned the alphabet. We know what the P, Q, R, S, and T mean. Now we need to learn how to read the page the story is printed on. This means getting comfortable with the grid paper and making some key measurements, like heart rate and access. And I want you to really pay close attention here. From a clinical perspective, and definitely from an exam perspective, this is where so many simple mistakes happen, just miscounting boxes. But the good news is they are so easy to avoid once you know the rules. So here are the numbers you just have to burn into your brain. At standard speed, one of those big boxes is exactly 0.2 seconds, which means, of course, that 5 big boxes is exactly 1 second. This timing right here is the foundation for absolutely everything else we're going to measure. Now, for calculating the heart rate in a nice, regular rhythm, I want you to remember one magic number. Just one. And that number is 300. This is your key to the fastest method out there.
We call it the rule of 300. It's so simple. You just find an R wave, that big spike that lands on a thick line, and then you count the number of big boxes until the next R wave. Then you just divide 300 by that number. So if there's one box between them, the rate is 300. 2 boxes, 150. 3 boxes, 100. 4, 75. It's a quick, easy, and really effective way to get the rate.
Next up is the axis. That's the overall direction of the heart's electricity. The quickest way to check this is the 2 thumbs up method using leads I and AVF. If the QRS is pointing up, or positive in both of those leads, that's 2 thumbs up, the axis is normal. If lead I is up, but AVF is down, they're leaving each other, that's left axis deviation. If lead I is down and AVF is up, they're reaching for each other, that's right axis deviation. This can give us clues about things like an enlarged ventricle or a conduction block. All right, now that we have the alphabet and we know the rules of the page, it is time to read the whole story. And the absolute key to clinical interpretation is having a system, a repeatable, reliable method you use every single time. And this is the one I want you to use. Step 1, calculate the rate. Step 2, determine the rhythm. 3, find the axis. 4, measure the intervals. And finally, step 5, examine the morphology, the actual shapes of the waves. Following this exact order is what separates the experts from the novices, because it makes sure you never miss a thing. So let's use that system and apply it to a few of the most critical, high-yield patterns you'll see. These are the kinds of ECG findings that you absolutely, positively cannot afford to miss in a real clinical setting. I want you to commit these associations to memory. See a wide QRS, your first thought should be that the rhythm is coming from the ventricles. See no clear P waves, you should be thinking about atrial fibrillation. An ST segment elevation, that is the classic urgent sign of a heart attack, a myocardial infarction. Recognizing these patterns fast can literally save a life. So let's bring it all back home. The real secret to reading an ECG isn't about memorizing 1,000 patterns. It's about understanding. It's about connecting the waves to the electrical pathway. P is the atria, QRS is the ventricles, T is the recovery. And that difference between a narrow and a wide QRS, that tells you if the heart's superhighway is open for business or if there's a traffic jam. That is the core of everything. So, you see, that jumble of squiggles is no longer a code to be cracked. It's a rich, detailed conversation that the heart is having with you, beat by beat, moment by moment. The only question left is, are you ready to listen?